Welcome, everyone. My name is Jeremy Schwartz. I'm an associate professor of medicine at the Yale School of Medicine and of epidemiology at the Yale School of Public Health. I'm also the lead of the faculty network development at the Yale Institute for Global Health. I'm delighted to welcome you to today's conversation series event with Winnie Byanyima, the executive director of UNAIDS. I'm coming to you today from Uganda, where I'm currently living and where I've been engaged as a clinician, educator, and researcher for nearly 20 years. So the fact that Winnie Byanyima, our guest, is a Ugandan makes this even more special for me. In addition to YIGH, today's event is co-sponsored by the Walker Fund at the Macmillan Center and the Center for Interdisciplinary Research on HIV and AIDS at Yale. It's a pleasure to be with all of you here today. Many of the drivers of gender inequality in the HIV epidemic are the same as those driving inequality in the COVID-19 pandemic. For example, as we've seen during the COVID-19 pandemic, women and girls are at heightened risk of domestic violence and inadequate access to essential health care, including HIV prevention and sexual and reproductive health services. To better prepare for the future, during today's conversation, we will discuss the imperative to address the underlying social factors, including gender inequality, that exacerbate these pandemics. These issues of equity and social determinants and their impact on health at home and around the world are important for Yale faculty and students. The Faculty Network program at the Yale Institute for Global Health is proud to support almost a dozen networks that address some of the greatest challenges in global health. You're welcome to learn more about our program on the YIGH website. In tandem with this event today and in close collaboration with CIRA, the Center for Interdisciplinary Research on AIDS at Yale, we launch the newest addition to our Faculty Network program, known as the Yale Global HIV/AIDS Research Network, or GARNER for short. This new network will aim to bring together Yale faculty and other partners to support global interdisciplinary research on the implementation of HIV prevention and treatment services that reduce disparities and work toward ending the HIV epidemic. To introduce Winnie Byanyima and to moderate today's conversation, I'll now turn this over to my colleague, mentor, and friend, and one of the leads of GARNER, Dr. Luke Davis.
Thank you very much, Jeremy. Hello, everyone. My name is Luke Davis, and I'm Associate Professor of Epidemiology and of Medicine at Yale. I'm also the faculty lead of the International Research Program at the Center for Interdisciplinary Research on AIDS at Yale. And I'm a clinician and researcher who's been working in Uganda for about 17 years as part of collaborations at Makerere University on TB and HIV. On December 1st, we will commemorate World AIDS Day, a day when we will reflect and renew our commitment to ending the HIV epidemic. 4 decades into the HIV response, inequality still persists for the most basic services like testing, treatment, and condoms, and even more so for new technologies. Young women in Africa remain disproportionately affected by HIV, while coverage of dedicated programs for them remains too low. We see similar issues in the response to COVID-19. The theme for World AIDS Day this year is Equalize, where we will recognize the inequalities which perpetuate the AIDS pandemic and make sure that they are not inevitable. This year, World AIDS Day will be a call to action, a push for all of us to work for the proven programs and strategies that are needed to address inequalities and help end AIDS. With that in mind, it's my distinct pleasure to introduce today's distinguished guest, Winnie Byanyima, the Executive Director of UNAIDS. A passionate and longstanding champion of social justice and gender equality, Winnie leads UN's efforts to end the AIDS epidemic by 2030. She believes that healthcare is a human right and was an early champion of a people's vaccine against the coronavirus that is available and free of charge to everyone, everywhere. Before joining UNAIDS, she served as the executive director of Oxfam International, empowering people to create a future that is secure, just, and free from poverty. Winnie was elected for 3 terms and served 11 years in the parliament of her home country, Uganda. Winnie also led the establishment of the African Union Commission's Directorate of Gender and Development, and also served as Director of Gender and Development at the UN Development Program. She founded the Forum for Women in Democracy, an influential Ugandan non-governmental organization, and has been deeply involved in building global and African coalitions on social justice issues. She's a passionate advocate, and we're incredibly honored to have her here with us today. Welcome, Winnie.
Professor Luke Davis, I'm Professor Schwartz. Thank you for inviting me to be part of this discussion. And you have to tell me, because I'm not smart enough to know how you managed to be working in the sunshine by Lake Victoria, and I'm sitting here in damp and cold Geneva. You've got to show me how you do that. Thank you very much for having me, and I'm looking forward to an exchange with young people at Yale. It's a privilege. How do you want this to go?
Well, thanks, Winnie. It's wonderful to have you with us. The theme of World AIDS Day today of 2022 is Equalize. And I wanted to start just by asking you, because you have been a champion for this topic, why is equality so critical to ending the HIV/AIDS epidemic? And maybe more broadly, what do you think is required to achieve equality?
Thank you for that question. I keep saying that HIV/AIDS is an injustice because today we have tools for prevention, and we have tools for testing and tools for treatment. We don't have a vaccine and we don't have a cure. But what we have in between these tools that we have of every type that will work for children, will work for adults, will work for gay people, for all groups of people, that these tools are there. But yet, last year, we had 1.5 million new infections, most of them in Africa, and we had 650,000 people who died of AIDS-related illnesses. So in spite of what we have, what science provides, we still have people newly infected, people dying. And when you peel that and see who is being infected, who is dying, that's when you really see inequalities driving HIV/AIDS, as indeed they drive other pandemics, as we saw in COVID, as you rightly put it. Take Africa. And first, inequalities of every kind, gender inequalities, income inequalities, racial inequalities, and often where they intersect is where you have the highest vulnerability. So I can give you some examples. In Africa, in sub-Saharan Africa, adolescent girls and young women are 3 times as likely to acquire HIV as adolescent boys and young men. That's just looking at a gender inequality there. You also find in the cohort of 15 and 19 years of age, teenagers, that 6 out of 7 newly infected teenagers are girls. 1 is a boy, 6 are girls. It tells you the higher vulnerability of girls. And why is that? It's driven by gender inequalities, unequal opportunity to education, unequal opportunity to sexual information, unequal access to services. So these, and sexual violence, which is actually a result of a gender inequality. Sexual violence is an indicator of gender inequality. So you find that inequalities are driving the higher vulnerability of adolescent girls and young women. 4,200 adolescent girls, young women are infected you might say every year, no. Every month, no. Every week, 4,200. It's a crisis. So then, still talking about inequalities, take the United States where you are, where many of the students are. Black people are 8.5 times more likely to be diagnosed with HIV than white people. That's just taking a racial difference. But if you take it further, you find that Black gay men in the United States have a 1 in 2 risk of contracting HIV across their lifetime. 1 in 2 Black gay men in the richest country on earth. This is a higher lifetime risk than the average in Uganda, low-income country where I come from, and almost as high as the risk in hotspot regions like South Africa and Zimbabwe. Think about it. When 2 axes of inequality come together, sexual orientation and race, you see the vulnerability, the risk rising much higher. So inequalities, I could give you more examples. In Canada, Indigenous people are several times more vulnerable than the rest of the population, and so on and so on. So we see, and I have many good examples, but time. So we see that inequalities, denial of opportunities, denial of services, unequal access to services, discrimination and stigma, which result in inequality of opportunity and inequality in access to services, all drive HIV. Close them, reduce them, and then you will see vulnerability and risk dropping very much. I'll give you one last example. In Malaysia, where there's a concentrated epidemic, where same-sex relations are criminalized, men who have sex with men are 72 times more likely to be living with HIV than the general population. Not 72 times, 72% more likely to be living with HIV than the whole population. Now you compare that with Thailand, another concentrated epidemic where same-sex relations are not criminalized. Men who have sex with men are nearly 12% more likely to be living with HIV. 72, 12. So just removing the law that hunts down gay men reduces their vulnerability. So that is why we say equalize. Equalize, because when you equalize, when you close the gaps, you reduce the risk for others. And it also goes for deaths, because deaths are a result of not staying on treatment. And when you have full access to treatment and you have an equal right to treatment, then again, the risk of dying is less. So close the gaps by removing those laws that discriminate, that drive stigma, equalize opportunities of education, of information, of access to healthcare, of social protection, and then you will reduce the risk and also the deaths. A long answer.
Thank you, Winnie. We know that at this time of year, we're thinking about the global HIV/AIDS epidemic, but of course, it's many different epidemics affecting many different people. And I think you've highlighted some of the unique, barriers to delivery of some of the gains of science that have been great in the field of HIV/AIDS, but also gains in giving access to people. We need to go further in giving equitable access to everyone to these life-saving interventions. I guess as you talk about some of the drivers, some of the drivers are similar around the world. Stigma may vary based on the population, but we know stigma and discrimination, whether it's adolescent girls and young women, as you were talking about, or Black gay men, these are important factors. I guess another factor that I'd love to hear you talk a little bit about are economic inequalities. You mentioned that in your first set of comments, and I think we're all familiar that we're facing a growing worldwide economic crisis, some related to the recent COVID pandemic and also to other factors, war in Ukraine, et cetera. And this has had major effects on societies around the world in 2022. I know that you often write and speak about how such economic factors, whether we're talking about inflation or more specific issues like global vaccine distribution, how these can drive health inequities and inequalities. And I'm just curious, given that you've been very outspoken and a strong advocate, how do your perspectives on economic justice influence your work in your role at UNAIDS?
Look, I'm glad you raised that question. And I think here at UNAIDS, our approach to fighting HIV/AIDS has been leaning very heavily on the biomedical side, less on looking at the social determinants, the structural barriers that need to be removed. So we do not even have sufficient data that we would use to make this linkage of economic inequality and vulnerability to HIV. But slowly we are pulling it together. For example, we know that overall people in urban areas have significantly higher HIV prevalence than rural, but that the urban poor have the highest prevalence of all in country after country, the urban poor. We also know that in Namibia, while 8% of richer people, non-poor, if you could say so, in cities are living with HIV, 15% of the urban poor have HIV at last measure. So we see a correlation between income inequality as well as all the social factors that come with poverty and higher vulnerability. But now, if you also look at who gets services, you see them skewed towards richer populations, towards urban populations, and less to rural poor. That is also, you see that in terms of access to services, who is falling out of treatment, for example. So in terms of economic injustices, we see this also at the national level. At the national level, you see countries that have the highest burden of HIV, struggling to pay debt, and that debt keeps increasing and taking more and more out of the total budget and squeezing out expenditures on health, expenditures on education. Let me tell you what really shocked me most was that in the midst of the crisis, the COVID crisis, when countries that are rich were pouring trillions, 17 trillion was put into the recovery, cushioning the economy of rich countries. That's not talking about the money put into buying the COVID vaccine. Developing countries, middle income and low income, were continuing to pay debt, to make debt repayments that were 4 times, several times, sometimes 4 times more than their health budgets. Imagine that. In a time of illness where there was a killer disease, plus other diseases like HIV, developing countries spent 27.5% of their total budget, these are the poor countries, on debt repayments alone, about 1/3 on debt repayments. That's, as I said, 4 times more than the health spend, 2 times more than the education spend, and 12 times more than social protection expenditure. This is an injustice. In times of crisis, even you at a family level, when you are in a mega crisis, you go to the bank and you schedule your debt. You're given a breathing space so that you recover and then you can pay. But this was not possible. So we saw at the same time, by the way, we calculated that every day the rich G20 countries who are sitting right now, receive $136 million per day in debt repayments from poor countries who are struggling just to keep services going in the health sector. So this is an injustice. We do not have a global mechanism, international financial mechanism for cushioning countries in times of crisis like pandemics. The IMF was created after the Second World War for the purpose of cushioning countries from economic and other shocks. But look, when COVID hit and entire health sectors were stretched completely, healthcare systems, they came together at the IMF, they created new money, which they call special drawing rights, but they distributed it according to the formula that exists, which is that the bigger shareholders get the bigger share. So they allocated the new money to the rich ones who didn't need it. It was a scandal. There was a lot of pressure from many of us saying this is not meaningful. The ones who need most, this system of cushioning isn't cushioning them. They came back now and said, okay, we shall take our new money and we will loan it to you at a concessionary rate. Imagine, SDRs were created to give you money without incurring debt, but now they are offering them to the low-income countries with the debt. So there isn't a system to cushion countries from pandemics, and that's really an injustice. Healthcare should not be something that waits for other deals to, this is life. The second example is about access to medicines. I don't have to repeat the story of what happened during COVID, where a handful of companies, were allowed to decide how much vaccine is produced, at what price it is sold, and who can buy it. Poor countries pulled their money together. Africa tried to pull money together. They were told to stand in the back of the queue while richer countries took everything, stocked up for themselves, hoarded, and even expired drugs, vaccines expired. This happened because it is allowed to happen, because the trade rules allow medicines, life-saving health commodities to be sold the way you can sell a luxury item like a fancy pen I'm holding here. How can that be? But it's allowed. We went to the TRIPS, the WTO body that regulates intellectual property, to ask that there is a waiver that allows all countries to take that technology and produce it for themselves. No, it was not allowed. And who refused? A handful of countries whose companies were reaping the billions. So we saw Pfizer make $137 billion in 1 year alone of profit from a drug that had been produced with the help of public resources from you American taxpayers and German taxpayers. And we did an opinion poll. Ordinary Americans, Germans, British people were saying no profit should be made from these vaccines before the COVID pandemic is over. But the companies held the monopoly. So we argue against these trade rules that treat life-saving treatments the same way they treat luxury items like a Gucci handbag. We argue against that. It's an injustice. So these are the things that are driving ill health globally. We need to change the global rules of trade. We need also to deal with the rules of taxation. These companies are not paying their fair share of taxes. They are able to hide through many tax loopholes, to channel their profits from one country to another, put it in tax havens where it's not taxed, And that denies small countries, poor countries, the resources they need to pay for the health of their people. We've calculated the billions that are transferred to tax havens every year that developing countries lose. It's phenomenal. It is several times over the little aid that is received. So sometimes people make health an issue of aid. Yes, I'm sitting here using an aid check from rich countries, but it shouldn't be like that if we corrected the tax injustices in the global corporate tax system. So you see that global rules enable or drive inequalities which result in ill health of some, death of some, and huge mega profits for a handful, for few people. So that is what we mean about the economic injustices in the global system, but also at the national level. We have our own governments that are not prioritizing everybody's health. In much of Africa, probably more than 33 countries, health is paid for by the poorest people. User fees are collected for people to get, and many times people die of malaria, babies die of diarrhea because a mother or a father can't afford the small user fee charge. And why is that? You see money being channeled through to other sectors, to large public administrations that you don't need, to defense expenditures, to all kinds of expenditures that are less important than people's lives. So that's an injustice. So we see how economies, the way they are managed, the rules in the trade system, in the taxation system, the rules in technology, how technology is produced, intellectual property, rules, all these work against justice and health and drive pandemics such as HIV. I should stop there.
Thank you, Winnie, for highlighting. I think the audience is chiming in and appreciating your examples, helping us understand sort of this issue of equality. And I think particularly the economic examples, that the structural factors that are baked into our system at the macroeconomic level. You talked about some of the microeconomic challenges that individuals face, and it's very, I think, helpful to know what the barriers are. And you've also provided some solutions. This is a conversation with Winnie Byanyima, and I encourage those in the audience to add your questions into the chat. We will get to a point in a few minutes where we'll be taking those, but I do have a few more questions that I would love to ask. And one of the factors—
I know you do. Look, I just want to give you one more example because this is close to home. Pharmaceutical companies in the United States of America paid more than $100 million in lobbying fees, lobbying your Congress and Senate. Why? It is not because they are paying legislators to find a cure for malaria. No, it is so that they can keep the price of medicines high. This is part of the problem. The corporate greed and the rules I was talking about in the national systems that allow certain things to happen. Lobbying by pharmaceutical companies to keep prices high, to keep taxes low, hurts ordinary citizens. Hurts not only ordinary citizens in the United States, but all over the world, because they are lobbying about prices of goods that they are going to sell also to other countries. So these are the rules that have to change if people have to have a chance to access medicine that is cheap, that is affordable. Sorry, I wanted to give that example of lobbying as a rule that hurts the health of people.
Enormous amount of money directed to something that is working against the efforts that all of us are focused on. I'm curious, the numbers of people displaced by war and economic crisis and natural disasters is a topic that's of special interest to a number of researchers here at Yale and clinicians as well. And these numbers have kind of climbed over the last decade. We know that women and girls comprise more than half of refugee and displaced people worldwide. And they're also, in that context, at a greater risk of gender-based violence. And I'm just curious, given your perspective, I know you've worked in the area of humanitarian crisis in your previous roles and understand it well. What can the global health community do to support displaced populations, refugee populations, populations living in humanitarian crises that are increasing around the world, so that we can optimize the HIV/AIDS response in these sort of emergency type settings?
Crises are increasing. These numbers of displaced are increasing because of the complexity of issues of war, climate crisis, poverty. So people on the move are increasing, and those who are displaced are also increasing. We have to find ways to get health services to reach them. And the surest way, we know from experience of working on HIV/AIDS, is to support communities to deliver services for themselves. We found this to work, say, in Ukraine. Ukraine is a country that has the second highest burden of HIV/AIDS in Eastern Europe and Central Asia, that region. It's second to Russia in terms of numbers of people living with HIV. Many are people who inject drugs or men who have sex with men. But Ukraine, unlike Russia and many of the other countries of Eastern Europe, had a system of delivering services for HIV prevention and treatment that were driven by communities. Ukraine empowered communities to lead services. So you would have gay communities delivering services to gay people. You have people who inject drugs trained to serve people who inject drugs. And you have communities, geographical communities serving themselves. Now, when the war broke out, it was possible for many of us who are in global health to follow these communities and continue to support them because they were moving with their people and they knew their people and they could find them. And most importantly, for a person living with HIV who, say, crosses from Ukraine to Moldova or from one part of Ukraine to another, this is not the first thing you want to do to identify yourself as, I'm living with HIV. No, it's your secret. You fear stigma. But when you are fleeing with your community and your community leaders who run the service are looking for you, have your cell number, they will find you and you will be able to get on your treatment. So we found that it was quick for us in a couple of months. First, they were cut off from services, but in a few months, they were back on services because of communities leading. So for me, the biggest solution is, of course, to empower communities to lead services. They have the resilience to adapt when things go bad. But secondly, of course, is to put the resources down, to put down the resources that are needed to reach people in trouble. This humanitarian spirit is so important, and I think that this is how our humanity is tested, to be there to save lives. And the last one is to solve the root causes, the conflicts, the climate crisis, stop roasting our planet. We've got to stop the displacement. Back to you.
Thank you, Winnie. I really appreciate your highlighting the power of peer-led interventions in so many ways. I think there's a number of examples in our HIV/AIDS community here at Yale, specifically with respect to the war in Ukraine, responding to the needs of people who inject drugs and their need for opiate agonist therapy, supporting people in HIV care, and then just responding more broadly. Many in the Ukrainian and Russian communities here have responded. And I know there's other examples. We've seen it in Uganda as well. I wanted to ask you a bit about, given the audience that we have here, and I think the forward-looking view of World AIDS Day, what are your comments about how we might educate and train the next generation of students, researchers, providers, advocates, and community members, kind of highlighting what you had said there about peer interventions? How can we harness this group and help them contribute best to meaningfully addressing inequalities as we're focusing on today and improving the global HIV/AIDS response?
That's a very hard one because I'm not a professor. I don't know how to teach. But let me think about young people. I think that first of all, young people are today not getting as much information about HIV/AIDS as an older generation. And secondly, young people, particularly in Africa, but I also see it in other continents, are not getting sexuality education, which is critical for life. Young people are going through school without knowing about their bodies, especially girls, and knowing about how to live a healthy life and how to handle their sexuality as they become teenagers. Young boys grow up with toxic masculinities. They understand their gender in a violent way and do not have a healthy, peaceful masculinity. So there's a need for sexuality education for boys and girls in all our schools so that boys grow up with a healthy notion of masculinity and also a positive attitude towards health seeking. And girls also need to be empowered about their bodies and to know how to own their body and make choices for themselves. These things aren't happening and lives are being lost of young people. In terms of at a higher level, I think that we need the space, the academic freedom to use it to discuss difficult issues like human rights, LGBTQ rights. In a country where LGBTQ people are criminalized, you want to have a debate at a university like Makerere, where maybe you are. There should be the freedom for young people to debate these issues because it is from centers of intellectual centers like universities that we can challenge stigma and discrimination. I think education on human rights, on women's rights, and using the space, the academic space, to vocalize, to debate, why can't there be a pride march at Makerere? If it can't happen outside, within the gates of the university, why can't it happen? So we really need to challenge young people about human rights and women's rights. I see young people and I get mad. Young people in my country, young men who are little patriarchs in the making, who they already are. They've got an attitude about being superior to women. This is education coming from tradition, religion, and so on. We have to challenge it. This is an equal world. So I see the importance of teaching human rights to all students, science students, arts students, and women's rights, and debating. This is what I can say about health, because health is ultimately a human right. It is not just something to trade and or give away to rich people. It's a human right, and we must center it around human rights and focus on it as a human right.
Thank you for those inspiring words. We want to now shift in our last 20 minutes so together to open up the questions to some audience members. And I'll start with one from Edward Kabagambe, who is asking about cardiovascular diseases. As we all know, these are emerging as major comorbidities in HIV/AIDS patients, as we've been able to enable patients to live longer with HIV/AIDS. And the question is, are there coordinated cardiovascular disease control efforts especially thinking about low and middle income countries for preventing cardiovascular disease in HIV populations? I think specifically Edmund is interested in high blood pressure and stroke.
What is the question?
Are there coordinated cardiovascular disease control efforts that are happening to prevent cardiovascular disease in HIV populations? I know there are some activities that are going on among faculty members here at Yale, but more broadly, what is your perspective on integrating care for chronic diseases, especially cardiovascular diseases, in people living with HIV?
I think as the years go, and we are now 40 years since HIV was first isolated, and as treatments improve and people live longer and longer lives with HIV, the issues of comorbidities have become very important, that people living with HIV and how other diseases affect them, including high blood pressure and others. This is becoming more and more important in understanding. Of course, for us, as a global response on HIV/AIDS, the big ones that we pay attention to are TB and HIV, because there's a strong correlation. The most deaths, AIDS-related deaths, are deaths from TB. And then now increasingly, we see that mental health is so important for many, many people who live on treatment for a very long time. It affects their mental health. And this is something we have not worked on for long. About high blood pressure, I think that is probably lower down the list of priorities that we work on in the global HIV response, but it's probably an important area, and I have not read much about it.
Well, thanks for your thoughts there. I'd love also to talk a little bit about, we highlighted, and you highlighted earlier, this issue of adolescent girls and young women, but women more generally being much more vulnerable to the effects of HIV. And one of the questioners is asking, just given this disproportionate impact, could you comment a little bit on coordinated and concentrated efforts to tailor treatments specifically to women? One example is given is sort of breaking the cycle of maternal to child transmission, but I know there's many other women-specific examples that'd be interesting to hear your perspective on.
That takes me back also to the social determinants. Do you know that it is a shame that children are left behind in the HIV response? That globally, 75% of all people living with HIV are on treatment. But the number for children is just 50%. 50%. So half the children living with HIV today are not on treatment, they are dying. And we still have countries, many countries, even in spite of the treatment that is there, that still have mothers transmitting HIV to their babies. And you have to ask yourself why. Goes back to inequalities. When you look at those countries that have high rates of mother-to-child transmission, they are countries, they are the same countries, or those countries have a high, or let me put it this way, high numbers of teenage mothers. You find that the biggest number of the mothers who have transmitted HIV to their babies are actually children themselves. They are girls who've given birth. They are 16, they are 17, they are 18. And and they are poor. And this is the reason why they transmit. First, as you know, if you are living in Africa, if a girl gets pregnant, perhaps 7 out of 10 chances are that she will leave home. She will go stay with an aunt. She will go to stay with her sister. She'll go to hide at her boyfriend's. She's shunned by the family and the community. That movement alone means that she moves away from where she has services, where she knows. She's in hiding. Those are factors that lead to not accessing services. Because if she went for antenatal, she would get that quickly tested and put on treatment, and she wouldn't transmit. So we have to solve many issues. It's not enough to put medicine in the clinics, ARVs in the clinics. We have to solve those issues of teenage mothers. And when we don't connect these two, we keep saying, but why aren't the numbers coming down? We have some programs. I've seen some programs where they tell a mother to bring the man who made you pregnant. They disappear. They don't come back. Because the circumstances are that she dares not even tell whoever made her pregnant that she's HIV positive. So addressing those social factors, addressing those barriers that stop young women from coming forward to save their babies is important. And once the baby is born positive, they also fear the stigma of taking the child to be put on treatment, because then the child will know and then her secret will be known. And I've just come from Jamaica. I went to a community-led service. I met 5 users of the service. 2 of them were women who had been using the center for 18 years. They'd been going there for their ARVs. They laughed, they joked, they were at home with the leaders of the center, the service providers. When we talked, I asked them, I said, they had children. I said, do you tell young women in your community to be careful, to save themselves, to prevent, to ask for safe sex? Do you tell them? They said, what? We cannot say the word HIV. Nobody in our community knows that we are HIV positive. If we talked about HIV, we would be known and we would be shunned. Imagine, 18 years, their communities know nothing. Their friends who know their secret are those who come to the center. So imagine this kind of stigma, what that means for a child growing with HIV, who is HIV positive. It's too hard. So many moms will not tell their child and will not let them have treatment and will watch them die. So we have to address those issues of stigma, fight discrimination before we can have everyone come forward to get service.
Winnie, there's a lot of interest in sort of the effects of COVID-19. Some people asking about whether it affects HIV outcomes and what's the burden of COVID-19 on people with HIV, but maybe more broadly, quite a few questions about how COVID-19 has affected the way we deliver HIV services, whether you're thinking about HIV testing or even some of the social factors. Some are highlighting just the role of domestic violence kind of during the COVID-19 pandemic. Maybe the broad question would be then is how has COVID-19 changed the task that you face and that we all face to kind of address HIV/AIDS going forward with the pandemic?
Let me start with what is positive. So that excites me. Some things changed for the better from COVID in our HIV response. Some policies, for example, that we had been advocating and that we know would help people to stay on treatment and be safe and be virally suppressed, finally came to happen, like multi-month dispensing. We had been telling many governments that, please allow people who are regular in coming for their treatment to get a stock of drugs for 6 months, or at least start with 3 months, so they don't have to come every month. But many governments, fearing that they are not in good control of the supply chain, wouldn't do it. So they were still requiring people to come every month, sometimes twice a month. But when COVID hit and the public safety measures required people to lock down people, then they had no choice but start rolling out multi-month dispensing, and then they realized that it works, that it actually saves them, and because people were not coming to the clinic. Then the other innovations came in. You got people, I'm always proud to tell this story. In India, people living with HIV getting on their bikes, collecting the ARVs for a group of them and going around distributing to each other. So they would take turns. These were innovations. And then using the phone. Finally, telemedicine came to health, to HIV, because now they were using the phone to locate people, to drop off supplies, because people fear stigma. They tell you where to drop it, they pick it up, but it's all on the phone. So all these innovations came in the way services are provided as a result of the public safety measures. But bad things also happened. Violations of human rights. People who are already stigmatized tend to be targeted, scapegoated when there's fear and panic in society. So you got gay men suddenly becoming more oppressed, more victimized. You got sex workers being thrown out of their homes and being told that they are victors of the coronavirus. I came to Uganda to see President Museveni because there was a group of about 40 or so gay men who were found hiding in a shelter and arrested and taken to prison for nothing. And horrible tests were done on them. So I went to see him and asked him to have them released. Then he said to me, I need to tell you this anecdote. He said, but they are in prison because they violated COVID rules, our COVID laws here. There are not supposed to be so many in one building. Can you not? I said, but it's a shelter, Mr. President. These are people who run away from their homes. They're in a shelter. I said, well, can't you UNAIDS build them many houses? What kind of question is that? I said, we don't build houses for people. This is a kind person who's given them a shelter, and that's where they stay. And he said, well, we're going to see, but this is a breach of our rules. We don't want many people crowding. Then I looked at him. I said, Mr. President, he was in his state house in Entebbe. Said, Mr. President, but down the road there on Bugonga Road, there's a group of 50 women in one house. Why haven't you arrested them? I said, what? Who are those? I said, the nuns. They're in a convent. And he burst out and laughed. He said, you got me. But it's totally ridiculous that gay men staying in a shelter were a risk. But in all these other places, they were religious communities, nobody was touching them. So discrimination was rampant, and we saw the violation of human rights. We issued a report about it, drew attention to it. So those were but in terms of the general response to HIV/AIDS, some things also hurt us, were thrown off track because governments ran out of money. Both the donors were pouring money into saving their people and were putting in their economies to keep them growing or at least stable, and we are cutting the money, the little money that goes to supporting HIV responses in developing countries. We fought to keep this money flowing, and we are still fighting, but we were hurt because many countries still depend on the American program, PEPFAR, as well as the Global Fund. And we were seeing, but actually I have to say this, credit to the United States government. In the middle of all that, they actually increased their contribution to some of our work, but some other countries reduced. We also saw, sadly, that the same story of what had happened with ARVs when they were first produced, and it took 10 years before they became available in the South because of the price, because of the monopoly of companies. We saw it play out again, and we had tried to say, let's learn the best lesson. 12 million people died mostly in Africa while we waited for the price to come down. Does it have to happen again? But no, we didn't learn the lesson. So again, we saw the same rules working to hurt a global response. But now we came back fighting. We are now fighting for long-acting injectables. Long-acting injectables for prevention are now available. If you are in New York, you can have it. You can get a jab, and for 2 months, you're safe. You can have sex, and you will not with someone who has HIV, but you won't contract it. If you're in London, you can have it. It's affordable, but it's not available for a gay man yet in South Africa or in Uganda or in Kenya. The price is still too high, and the countries cannot import it yet. We are fighting for this price to come down. Long-acting antiretrovirals will be a game changer for young women and girls, because young girls and young women are most of the time hiding, don't want to be known that either they are having sex or they are positive, and can't negotiate safe sex. But imagine having an injection that prevents for 6 months, or you have the ARV and you don't have to swallow a tablet. Nobody has to see. If you're a girl, you're not swallowing a tablet, you're not causing attention to yourself, but you get a jab every 6 months. It will be a game changer, but it will be available first in rich countries. We'll have to fight to get the price down. Some people will die before the price comes down, but we'll do it. We have to do it. And you young people must be part of these campaigns. And it was the alliance of gay men in America and Europe with people in the South that brought the price of antiretrovirals down, and the leadership of people like President Mandela. So it will take global alliances to end AIDS. to bring prices down, to have access to medicines, to the best of science, and to remove these laws and policies that create barriers for people.
Winnie, thank you. This has been a remarkable conversation. I think we could easily go for another hour. The audience has been inspired by your comments, and I think you've given both a general framework for thinking about where we're falling short, namely addressing equality, and also given us room for hope that some of the victories that have been won in the past for standing up for economic justice and standing up for the those who are adversely affected by stigma and discrimination, that we can carry those forward with new technologies and do better. We thank you so much for joining us today, and we'll be following your work closely, and we'll take forward your words with inspiration.
Well, thank you so much. And greetings to my brothers and sisters in Uganda. Thank you for being with you. And I enjoy engaging with students and intellectuals. Thank you.
Thank you very much.